healthcare system is broken, but it doesn't have to be. This is Revenue Cycle Optimized by Infinix Healthcare. We discuss the latest challenges in the revenue cycle space and provide actionable tips on how to overcome them at your organization.
Hi, everyone, and welcome back. I'm Stuart Newsome, and today we're tackling a topic that continues to be a thorn in the side of healthcare providers and revenue cycle teams, and I'm talking prior authorizations. And particularly today, surgical procedures, prior authorizations for surgical procedures. So the title that we're going to discuss today is The Hidden Hazards of Surgical Prior Auth. We've all seen what happens when something slips through the cracks. There's delayed surgeries, frustrated staff, and denials that never should have happened to begin with. I've always thought that was kind of an oxymoron for prior auth, yet denials still loom large. But what's really behind those denials? Well, and what can we do, not just as a revenue teams, but also as a full care ecosystem to really prevent them? So joining me once again is Bowman, who's VP of Strategic Accounts, and someone who's been on the front lines of this. He and we've been comparing notes, gathering insights from the field, and today we're just going to lay it all out for you. So I hope everyone's ready. So how are you doing, Bo?
Hey, Stuart. Great. Thanks for the intro. I'm real happy to be here. Very germane and popular topic. I oversee our kind of medical practice and ambulatory billing division, and definitely been a kind of an upward trend all in on our surgical subspecialty support for authorization, and we've had to help our clients across the board. So again, popular topic. Looking forward to discussing it and seeing what insight we can provide.
Yeah, awesome. Bo, let's dive right in because I know we have a lot to cover and we'll take as long as it takes, but I know we want to keep the attention span of everyone on board here. So what are the most common reasons surgical prior auths get denied today? And how often are those preventable?
Sure. So, we support neurosurgeons, general surgeons, OB-GYN, cardiothoracic, pretty wide range, gastroenterology, ENT, and, lack of medical necessity is a tough fight. That's usually what we see more often than not as to why an authorization is either under approved or not approved or on delay to get approved. So, insurance companies require just thorough documentation as you prescribe the surgical procedure going forward. So, everything from documenting all of the diagnostic tests that have come forward, the pre-planning of those diagnostic tests based on patients' past and current conditions. So, we try and work real closely with the provider. We try and work real closely with their medical assistants, with their nurses, with their nurse practitioners to educate as much as we can on, hey, you got to have these 8 or 9, documents in place to prove the necessity. And, most of the time when we do a pre-review, then we'll get that authorization. But if you don't have that kind of full comprehensive view of what has happened to the patient on this journey leading up to their potential, again, diagnostic or exploration surgical procedure, that authorization will not get approved. And we're kind of back to the drawing board, if you will. A lot of it can be very preventable. But again, if you don't have the correct information, simple stuff like demographics and updated insurance information, oftentimes the coding will be put in from a reference guide used either by a provider or by a tool that they may have had that could potentially be outdated. So we'll work with them on providing the latest set of codes for that particular procedure. And then again, it's back to showing the documentation to support the coding. So, a lot of avenues there for wrong. And, that's why we're having the conversation today, is to show you and help you understand all the planning that needs to go in to get that authorization first time.
Yeah, I mean, you hit the nail on the head when it comes to documentation, because as long as I've been in this business, the old saying is, if it's not documented, it didn't happen. You're just not going to get paid. And there's a lot of little nuances to documentation. It really depends upon the type of procedure, also the insurance plan for that fact, all have different varying rules that go along with that. So with that said, can you talk about how payer portals and auto denial systems are contributing to the problem, especially, with those third-party platforms or TPAs?
Yeah, we've had to do more and more training because you really have to align digitally what the payer expects as they review the submission for the authorization. So, payers are increasingly using a lot of automated systems like we've discussed, using AI to make those decisions. But again, without a little bit of human interaction, we have seen these auto denials occur. And so oftentimes we have to get the client ready to, well, we're going to resubmit. Well, why do I have to resubmit? Why can't we get it through the first time? So, there's been a lot of concern around this from our providers that we support. And, what we're committed to is to make sure we understand what each of the major, for instance, BUCA providers is looking for when we submit on behalf of the provider. A lot of times, again, it's making sure the coding's in order, matches up with the diagnosis, matches up with the ICD and CPT. Those are all kind of important and, if you will, I'd say cause leading error issues in, if you will, this kind of digital age of using these third-party portals. And so, again, having the necessary checks and balances and having the right eyes on it to make the digital piece work is a piece that we believe heavily in and could help a client with if given the chance.
Yeah, and I think also there are times, and many times than not, that the third-party administrators probably don't communicate clearly with the actual payer themselves. There's a disconnect there, where there may be a no auth required, for instance, and then suddenly, bang, you're denied, because there is an auth that was required. It's because the third-party administrator is just going under the assumption of the last rule, and they didn't sync up with a policy change or something. And that's just one example. There are plenty of examples where that disconnect happens on their end. So, there's issues, big time issues on how that can contribute to the problem. So having, someone on your side to kind of help facilitate that and navigate that is extremely crucial. So speaking of, what's the impact of peer-to-peer scheduling delays? How are they affecting surgical timelines and patient care? And maybe kind of go into peer-to-peer.
Yeah.
Yeah.
Yeah. The peer-to-peer, man, I remember when I was a practice administrator, even like, in the early 2000s, and, we'd have 5 or 6 doctors lined up, all trying to get procedures, scheduled for Thursday afternoon or Friday, especially later in the year as the deductible is worn off and everybody wants to get in to have their procedure and recover timely. And, the patient's ready, the patient's, caregivers are ready, and we've done all the necessary. And then we hear back from the payer that there's going to need to be a P2P. And, I'd say the tough one there is, just the difficulty coordinating these busy surgeons and nurses. They have to literally stop seeing patients or assisting what they're doing with current patients. And we actually used to block their calendars, right? You have to block their calendar and say, hey, Dr. Such and Such, or hey, Mr. or Mrs. Nurse Practitioner, we need you to log in to this P2P at this time. Here's the chart. So there's this whole extra effort that has to go on to make sure everybody's prepared to have the successful, conference, if you will. Got to have all the doctor's notes, the imaging, what were the prior procedures were. The doctor had to re-educate themselves if there was physical therapy or prior treatments. And so, and then they give you 12 to 36 hours to get that P2P done, or they put you back on a kind of a restart. Right. So it is extremely time intensive for the practice, if you will, to put it on halt. So, again, whether it's your RCM team, your front desk team, your registration group, there needs to be a real, if you will, structured workflow in place when you do have one of your more acute diagnostic or acute surgical procedures coming up. So, you can potentially have to not get pushed back into the peer-to-peer, to talk through the validity, the authenticity, and why the provider has landed the patient at this need for the procedure, and being able to follow that workflow each time. Again, do I have the right ICD? Do I have the right CPT codes? Have the coding team looked at this? Does it match up with exactly what the doctor wants to do? Are there going to be an instance where they have to change course during the surgery? If so, what does that course change look like? And what documentation do we need to have prepped for that? Right. So there's this kind of future forecast that has to go on, and, using a combination of AI and human, kind of thought process is the best approach, especially in a high volume practice.
Yeah. Sounds like a Chinese fire drill, or at least you're trying to prevent that. Right. And I can only imagine, putting, all the components, especially the human components of providers, physicians, clinicians in place. Yeah. I mean, It's seeing patients, and that's all they want to do is see patients. Now I got to stop what I'm doing. So coordinating all that, huge lift, huge lift. So how, let's go back kind of to documentation and the importance of that. How important is specificity when it comes to documentation? You alluded to this earlier, but what kind of gaps are we seeing most often?
Let's take orthopedic surgery. That's a popular one. So it could be like, for instance, a simple right meniscus tear, and the doctor has the necessary documentation and all the necessary treatments have happened ahead of time. You do the scope work and you get in, and it's more than a right meniscus tear. Right. So there ends up being, what was going to be a 30-minute repair is now an hour and a half procedure where maybe even an implantable device was used or similar. Right. So now you have a completely different case post-op. We got to make sure the provider has a real thorough note on what happened while we're in there. And then back to specificity, it's important that we have all of the documentation, right? Because documentation gaps is probably the number one thing that we're missing. And then in regards to, why it was important to do that procedure at that time, again, listing all of the necessary codes, what the doctor found upon the scope, in this case, again, orthopedics, listing that out, thus, validating why he or she took that route during the surgery. So then, it's really kind of left up to your RCM team, post note, to restructure, re-explain, and be very specific about their billing methodology, really summarizing what happened during that case, right? So, the physician component, the billing component all have to align to get a clean claim through with that payer first time.
Yeah, yeah. And it's all about, I've always said, coding in particular is the language that payers use to understand what happened at that encounter. You have the documentation, you have the written record, or the dictation or recording, whatever the documentation is going to be construed of. But then it's the coding. So unspecified ICD-10 codes. I know ICD-10 is very granular. I'm so old I can remember ICD-9, but but ICD-10 brought that granularity. But still, using unspecified ICD-10s is just a kiss of death. And
We,
being
we,
very vague, you have to be very specific. That's what we speak of on specificity.
we see unspecified, and we also see, listen, just like everything else, coders and builders are going fast, right? They've got a stack of 70 or 80 they've got to get through in a day, right? So real important that your team is using something like the Optum 360 Encoder Pro, something like 3M, something that has the latest and greatest updates in it. Very commonly, we see out-of-date codes being used, out-of-date ICD specifics being used. And so again, it really is about education, taking the time to make sure your reference guides are updated, not using expired codes. Of course, Medicare updates the fee schedule every year, so we'll help clients update their fee schedule. That gets back to, hey, we've done our verification and eligibility. The patient is eligible for this procedure, but limited to X, right? So we've got to make the provider know, hey, we're going to get an authorization leading up to this far on the diagnostic surgical procedure for this patient. But if you need to do X, Y, and Z, that potentially has to be a second procedure. And then we have to have that discussion with the patient ahead of time so they don't end up getting billed out of network or getting a bill they don't deserve. So a lot can kind of go wrong there. So the better you are prepped ahead of time, then you're going to have that outcome you're looking for.
Yeah, and navigating that's very precarious, obviously. So what are the biggest challenges around appealing for surgical prior auth? Because you mentioned, post-op, post procedure and making that change. And of course, the denials are going to occur. So shifting now to that appeals process, particularly for surgical prior auths, how do they impact the team's workload?
It's tough because, again, you have the work in front of you that needs to get done for this day to get all of the cases, authorized and on the board for Monday, Tuesday, right? And then at the same time, you've got 7 or 8, you've got to rework, pull up your appeal template, review what was covered and what wasn't, You got to go sit with the doctor or the provider and say, hey, I'm going to need maybe an extra, note here about what you did or did not do to the patient and why. So again, there's all these steps, right, that have to go through. But what we've seen with successful appeals is that you followed a structured template that you have for that particular type of case each time. So, whether that's a heart catheterization or an ear tube procedure, having a structured template for your appeal letter that very specifically states the diagnosis from the beginning, and then explains the medical necessity, right? Kind of walks through that component, and then explains the care that was provided and has all the necessary documentation to maybe include additional documentation. Again, was there a change in course on the patient's care, either during procedure or post-procedure, and thus that hasn't been covered. So we're going to pick that back up in the appeal process, and then making sure there's synchronicity, right? There's a timeline that follows. So the reviewers, these reviewers they're RNs, they're MSNs, they're case utilizers, they're really smart people. And that's what they're trying to do. They're trying to put together a utilization timeline that makes sense, right? So it's clear that it's not overutilization or unnecessary utilization. And, a well-written either auto appeal or appeal letter that has that appropriate timeline and the medical documentation to support it is often turned over and won, frequently. And we've had a lot of experience with that. And we have people that do that solely for physician practices, ambulatory centers, and hospitals. And it's really more of an art, than a science, in my opinion. And just staying organized and structured is the key.
Yeah, you almost have to be, an artist. And when you say it's an art, it's almost rather than taking a procedural approach or
Sure.
a systems approach. There are systems in place, obviously, that you need to follow, but also just it's a lot of reaction. So you're not being reactive. You're setting yourself up for in anticipation of this appeal. You still have that structure in place. So it's not a reaction. Oh, now we have to file appeal. It's caught us by surprise. It may, but you're already prepared for just in case. Again, going back to that fire drill scenario, it's like, well, yeah, we have fire extinguishers, we have procedures of evacuation and things like that just in case of a fire. So we're not anticipating a fire. Same thing with denials. We're not anticipating the denial, but we have to be prepared for them and that appeals process, going through. So it's a lot of work, a lot of manual processes that are happening there. It's a heavy lift. So where do automation tools and AI agents help in this process? Where is
Sure.
human coordination still critical?
Sure.
In this equation?
It sounds simple, but just, form completion, right? To go and do a P2P or some of the things we've covered today, right? Or to finish an appeal, start and finish appeal letter, or to properly document a denial. Again, sounds simple, but just automation of your forms where your RCM team can go and fill in the necessary boxes. And again, whether that's a PDF or whether that's some other type of automation that either your practice management has set up or you've got other software built-ins that allow the team to have just, again, the form completion, the reply completion, have all that automated. So you're using the smart people that you have working for you to complete that component of it instead of either, having to write out, type out, use ChatGPT, whatever that looks like, to go back and again, if you will, recreate what happened to that patient using all the necessary documentation from the provider, from the practice management system. So that's what we've seen is, whether you've got built-ins into your practice management system or whether you've got add-ons that are using chat or they're using some of the AI agents that are out there today to help you complete that documentation faster. That's one piece of it. I'd say the other piece, so kind of where AI and some of the agents come in is again, using the tools out there that line up with how the claim's going to get approved the first time. And again, whether that's using an autocoder tool or an encoder tool, or whether that's using your automated claim scrubber that, again, you either have added on or that you have in your system and running it back through that tool, see what it puts out as a variance, knowing then how to go fix that variance and then the resubmittal. all of, I'd say, the combination of both those administrative and clinical application AI tools that are out there, educating your staff on how to use those, when to use those, will dramatically reduce work time and allow you to remedy, say, 60 or 70 either appeals or authorizations that need to get done or other denials that need to be worked on by the end of a work week, versus all that getting pushed to next week or you're back at the table trying to figure out, hey, do we need to hire more staff to get through these 300 claims that are still outstanding, right? So really
Right.
knowing how to use and knowing where to properly position the opportunity out there to use the AI agent, again, inform completion and, guides and references is, in our point, what we've seen be real successful for our clients.
Yeah. Yeah. It's always just tools where it augments the human specialists, I like to call them, in coordination with AI, using AI as a tool but
Mm-hmm.
using it properly, because a
Mm-hmm.
tool is only as good as using it properly and being trained on how to use that. Awesome. Well, that's all the questions, I have for you, Bo. I'm going to open it up for the audience questions right now. So there is one question here, Bo. How do you train or prepare providers to better understand payer-specific authorization requirements before submission? Well, that's the golden egg right there, right?
This sounds simple, but when I was a practice administrator and when we work with our clients today, we do quite a bit of lunch and learns. So we'll take a lunch and learn session. We'll take an hour-long session and we'll put up on the board or up on the screen, we'll just tackle Blue Cross one day, right? And so again, whether you're in an ENT environment, a cardiology environment, orthopedics, general surgery, and kind of your top 8, 9, 10, 11 procedures that you do that really are the meat of the practice in regards to the higher dollar claims you guys submit each day, you will start with Blue Cross and we'll say, hey, these are the 7 or 8 things, that have to be on the prior authorization documentation list when the specialist is assembling all of this to go forward with the authorization on Miss Johnson's upcoming case for next Monday, right? And so then, if you will, we kind of have a portfolio of knowledge built for Blue Cross. And then, next week we'll do the same exercise for the United and some of the United commercial plans. And then we'll do kind of the same exercise for Aetna and Cigna. So, knowing your market, reading the contracts that you have that drive the payments that come in on your claims is very important. We stress that to our administrators that we work with on a regular basis. But again, taking the time out, take an hour with the staff, with the team, and really, we use SOPs, standard operating protocols, for pretty much everything we do. So drafting what the payer expects, those top 8 or 9 things, and then, being able to put those in a 2-column system where they match up for everything you do, and then having a quality person look at those on a regular basis, make sure that the supervisors are on board with how everything's being aligned before claim submission is real important.
Nice. Okay, well, I have another question as well. This may be a little futuristic. I think it is. I've seen some programs do this or payers have the ability or say they have the ability for this, but have you seen any success with integrating real-time eligibility or documentation checks into the surgical scheduling workflow? So I think eligibility, there's 2 things there, eligibility and then documentation checks. So we have to pick one or the other or separate that out.
Infinix has a really nice eligibility platform. And within our platform, we can very quickly put in all the necessary information for the upcoming procedure and then very quickly get confirmation on, hey, does this patient's insurance have all the coverage it needs in there to make them 100% eligible for the procedure and thus get the provider paid? So that's one opportunity, right? Is looking at platforms out there that, hey, patient comes in on a Thursday, clearly, maybe they've got a bleed or maybe they've got something that's fairly urgent and the doctor wants to get them back in again into the ASC or into the hospital as early as Monday morning so, we kind of have to hit the stat button sometimes, right? We've got to hit the urgency button. So that'd be my, counsel is to use those eligibility platforms that are out there. Payers have some, Availity has some. Again, we provide an eligibility and insurance verification tools that allow you to do it kind very quickly. And then on your documentation check, again, it's very, very important to integrate those surgery schedulers, right? You're as good as your weakest surgery scheduler in a big procedural type practice, right? So real regular meetings with the surgery schedulers to make sure there's alignment, right, across all the questions and all either the phone calls or portals that they're hitting and having each day. So there's kind of some standardization that goes on, again, when they're going to get that authorization for that, right shoulder repair. Well, you can have a reference guide, right? You can build a reference guide for the major payers for right shoulder repair, and then have your surgery schedulers following that same one so they know to get those 8 or 9 things. And sometimes the delay there, though, right, is every insurance coverage is a little bit different, right?
Yeah.
Again, that's where it's good to have a partner like Infinix or a platform partner that you can put all of the inputs into, and we'll go get that information and bring it back.
Yeah, awesome. Yeah, there's so many moving parts. But yeah, to your point, not all payers are created equal, for sure. Not just in their coverages and policies, but also in their abilities to service their membership, so to speak, their beneficiaries. So with that, that's all. I don't see any other questions. Oh, here, wait a minute. There may be one more question here. So yeah, here's a comment. It's from Monique. So having providers use templates when dictating clinical notes can be a game changer to ensure specific verbiage is documented in the notes. Having the exact wording payers require to determine medical necessity. This also saves the provider's time, which we know is very important. Yep. Thank you, Monique. That's very, very insightful. Good advice. All right. Yeah, so there's no other comments. With that, Bo, again, as always, thank you for coming on and taking your time out of your busy schedule today. Also, just want to thank everyone else for joining us, and we'll see you next time.
Okay, Stuart, thanks.
Thanks for joining us. Subscribe to get notified when our next episode is online. For more information for how we can help you increase reimbursements at your company, check out our website at infinix.com. That's infinx.com.